Hi, welcome to the 9th episode of Ask Giri the Physio Show. Today we're going to discuss about Achilles tendon injuries. It's a very common with active adults and athletes. We're going to discuss what are the current concepts and the evidence which is leading us to the path of treatment. Let's go ahead and start. First, we're going to talk about what are the predisposing factors or the contributing factors to get Achilles tendon injuries. Right? There are intrinsic and extrinsic factors we're going to talk about. So if you see in the slide here, the extrinsic factors, it's a footwear type. If sudden transition from regular footwear to the kind of a minimalist footwear, or sudden transition from footwear running to the barefoot running, that kind of sudden transitions can happen. Also, that transition can give you some stress on the tendons as well. And also the terrain, the type of terrain you train on, that also depends on how much ground reaction force you're getting into the your ankle and your tendon. So terrain is also important. The activity level, okay, if you're very sedentary and suddenly you started running, or you started climbing stairs very much and change of directions quite a bit, so that can also affect it as an extrinsic factor. The intrinsic factors, which is inside your body itself, we talk about the range of motion, especially of your ankles. Okay, ankle dorsiflexion is about 20 degrees. The foot is coming up like that. So even a couple of degrees, if you are stiff in that range of motion, you can have a problem there too. And also weakness in your calf muscles. Not everybody can go on their toes and then stay there for about 20-30 seconds and come down and then all single leg. Not many people can do that. So you can check your calf strength, how good you are. You should be able to raise your whole body weight with one calf and able to stay there at least for 30 seconds. That gives you an idea of how good your calf strength is. Okay, if you have balance problem, please try this with holding on to something and don't fall on this one. And another intrinsic factors is the movement patterns of the kinetic chain. The whole kinetic chain, we're talking about the spine, the pelvis, the hip, knee, ankle and foot. How the whole thing is moving, right? It's not just about your Achilles tendon. We'll talk more about it as we go along. We have to make sure everybody is doing their job so that the Achilles tendon is not put into a lot of stress and unwanted loading patterns. So that is very important as well. And flexibility of the muscles and the fascia. So do not forget, fascia is a big thing, and in anatomy trains we call it the meridians of the fascia. So if you see the superficial back fascia, it starts from the forehead, it goes through the back of the scalp like here and goes on top of the neck, between the scapula or the shoulder blade, comes down to your lower back, thoracolumbar fascia, spreads into the gluteal area, gluteal fascia continues as a hamstring fascia into your leg, and goes behind the knee and continues and divides the calf muscle into compartments and converges and becomes the Achilles tendon, and then goes down and it forms a cup in the heel and goes forward with the connection into a plantar fascia and attaches in your toes. So that kind of a continuum, you should imagine a sheet from your forehead to the tip of the toes. That's the kind of fascia we are talking about, not just one small piece. So if there is any kind of restrictions along this pathway, that can also cause some facial issues in the Achilles tendon and the plantar fascia combo, that area. So I just want you guys to have the broad spectrum or broad picture about the facial connections. And muscles, yeah, definitely we need to see how the muscles are working in your glutes and your hamstrings and quadriceps and calf and everybody, how they are firing, and how is your foot muscles, the small muscles of the foot is firing. They all matters when it comes to Achilles tendon. You guys have to excuse my voice today a little bit because I woke up with a little bit of a blocked nose and some allergic sneezes. So I'm a little blocked in my nose, so my voice is not as crisp as it used to be. Okay, we'll go to the next slide here. The types. We are talking specifically to Achilles tendon right now. We usually classify the Achilles tendon into two portions, like mid portion tendinopathy and the insertional tendinopathy. So if you see, this is your Achilles tendon and this is your foot, right? This is your foot which is attaches to the heel bone. The Achilles tendon attaches to the heel bone. If this is my marker is your Achilles tendon, where it attaches to the heel bone, the bottom kind of 2 centimeters here, and that is your insertional point. That's if anything happens in that area where it attaches to the heel bone 2 centimeters in that area, it's called insertional tendinopathy. Anything from 2 to 6 centimeters on the top, that's called mid portion tendinopathy. Achilles tendon is the only tendon in your body which can have mid-portion tendinopathy problems, actually, changes happening in that area. It's a very unique tendon. It's one of the strongest and longest tendon in your body. That's why it's named as Achilles. And it can go through a lot of stresses in your body, right? Do not forget that it has to push off your body weight every time you take a step. And also when you're running, it has to bear sometimes 12 times your body weight. So that's how strong the Achilles tendon is. So let's move forward and also consider the Achilles tendon rehabilitation is not a simple rehab, because there's a lot of factors we have to consider when it comes to Achilles tendon tendinopathy problems and the treatments for it. So we need to consider three important things we need to consider. Number one is the pain, how much the patient is feeling it, right? And also function, how much the pain is stopping them, the things they do in terms of functional activities or sports activities, whatever it might be. And the pathology. How is the pathology? So those are three main factors we deal with in physical therapy practice when it comes to Achilles tendinopathy. So decisions, what kind of decisions we're going to take as a clinician when we work with the patient? What are we trying to achieve? The things we are going to do, are we going to try to affect the pathology of the tendon, what's going on in the tendon? Are we going to change the pain, what patient is experiencing? Are we going to restore function? So let's look at it, what we are going to do. We got to take the decision, right, what we are doing. So how we develop the tendon pathology? What happens? Why do we all get it? So with Achilles tendon, the research and the evidence says that mostly people can develop that throughout their lifespan. In contrary to the patellar tendinopathy is mostly an adolescent condition. There's a lot of evidence to prove whatever happens to your patellar tendon, the changes structurally, it happens during your adolescence. Even though you don't experience symptoms, you might experience even after, but it's an adolescent conditions. And if you take gluteal tendinopathy, it mostly happens in women after menopause. So every tendons, they kind of have a different symptoms based on the lifestyle and also life stages. But this Achilles tendon, anybody can have anytime throughout the lifespan, right? You can have a 14-year-old, you can rupture your Achilles totally when you're playing basketball, and a golfer at 45 and 50 can also get Achilles tendon. So depends on how much loading is going through that, how much stress is going through that tendon. So how we develop tendon pathology? Inflammation, number one. Collagen tearing, right? Collagen is a very strong tissue. Let's talk about it. And the cell-mediated pathology. There are a lot of cells in the tendon, tenocytes and things like that. What changes happening to those cells, right? That we'll talk about. Let's talk about inflammation now. In the tendons, research is showing that very less inflammatory cells are present in the tendon. Okay, there is some inflammatory mediators are there, but inflammatory cells itself is very less they are talking about, and they exist, but they're saying it is not the prime driver for you to feel the pain. So let's take that out of the context. Next is your collagen tearing. Collagen, I told you, it's a very strong tissue. They are almost coming out and saying it's impossible actually to tear the collagen unless if you have a cut or a cut injury to the tendon. Right, and the normal degeneration and loading patterns cannot tear the collagen, and it exists, but usually, as I said, it's a consequence of other injuries like cut injuries. I once had this patient a couple of years back. She was somewhere in the South America when she was closing the metal gate. The bottom of the metal gate, there was a metal piece sticking out, and it just cut her Achilles tendon. She had almost more than 80% tear of the tendon, and she came to us, and when I palpated, a very small string of tendon was left out, and we worked with that, and we got very good success. In 6 months she would return to a normal function, even with a little bit of structure left in that. So that has to give you some confidence that how strong the collagen is. Cell-mediated pathology. Cells do respond to load, and it does exist, and also this is, they're saying, the primary driver for pathology and the pain, not the inflammation but the cells, because they respond to load quite a bit. So why this is important? Why we need to know the pathology? Because it kind of relate to the rehabilitation process. Because if there is inflammation, we're going to rest a little bit, put some ice on it. Sometimes your doctors might prescribe some steroidal anti-inflammatory drugs. And if there is a collagen tearing, obviously rest to allow a little bit of a healing and the collagen tearing. But rest is not a good friend when it comes to tendon. Rest is bad for tendon, because tendon needs to load to maintain its structure and function. So too much rest is not good for at all. Do we need to change structure? Can we change structure by doing different things in physiotherapy? No, we cannot. Structure does not change that much. And usually when you have a degenerative process going on in the tendon, you develop actually more tendon cells. This was a surprise to me when I read this research article that pathological tendon actually has more good structure than the normal tendon. But we think always, oh, this tendon is pathological and it has weak and we should not load it more. But that's not true. Actually, pathological tendon has more good substance for you to load than the normal tendon. That's very important thing. And the very important thing here is you have to understand, look at this, just that's your tendon, right? You have to treat the donut, not the hole. So that's very important. Even if you have a little bit of a tear or if you have pathology going on, you have a lot of other good substance to load the tendon with. So where does the pain come from then? We talked about it's not related to the structure. There is not a lot of nociceptive driver. That means a lot of not lot of pain fibers inside the tendon. Most of the sensory fibers are outside. We call it peritendon, the sheath which covers the tendon. Inside the tendon, you do not have a lot of painful nerve endings there. And also there is also research saying that the central sensitization of the lower limb is not proven. That means you cannot have affect the brain by having pain for a long time. Like in other areas, chronic pain can affect the sensitization in the brain, but in lower limb it does not proven that we have central sensitization happening in the lower limb. So we came to know a little bit about the pain. So now can we change pain? You can look at the slides there. So the sensory nerves are, I told you already, it's on the sides there. It's not no sensory nerves in the tendon actually. Then to change pain, we need to direct treatments to the nerves, not to the tendon. And the nerves, how you're affecting the nerves by means of some modality. Shockwave therapy has a good strong evidence for affecting the nerves to change the pain patterns. Some injections and also filleting surgery is not very common, but it's the extreme case there we to get in there. So tendon pain causes dysfunction. That's the main thing we need to know, and destroys the performance. So what about function? Can we change it? What loads we should apply to rehabilitated tendon? Always imagine, especially when you talk about Achilles tendon, it goes through three types of loads actually. It does energy storage and release, compression load and friction. With Achilles tendon, the mid portion is mainly for the energy storage and release. The insertional portion where it attaches to the heel bone, that's mainly for the compression load. The sides of the tendon, the paratendinous area or peritendinous area, is mainly for the friction load because friction between the other structures beside the tendon. So this is a very important thing you should know when you treat an Achilles tendon a pathology. So Achilles tendon, the mid tendon, I told you it's for the energy storage and the release. It is the only tendon, I already told you about this, with the mid substance pathology. No other tendons in the body has that. And insertion area for the compression load, and the peritendon is for the friction load. So one tendon, three different types of loading patterns we have to consider when we are prescribing and developing exercises, when to give what kind of exercises and what is the protocol. We're going to talk about it a little bit later. So it's not only the tendons, it also we have to take care of the muscles, the muscle fascia, and also the whole kinetic chain, and the brain. Don't forget the brain. Because we have to take care of the brain and how you perceive the pain as well. Pain is not just a output from the tissue, it's a behavior pattern from the brain, right? That's what we know now. So the new concept is called the tendon neuroplastic training. It's TNT. There is a lot of papers published on that. You can read about it. It's basically how you're working with the chronic tendinopathy conditions, how you are retraining the brain for the people with chronic tendon issues. It can be tennis elbow, it can be Achilles tendon, it can be patellar tendon, and using metronomes and things like that. How you change the corticospinal tract behavior and the brain behavior using that training. So that's a whole different topic to discuss. It's called TNT, tendon neuroplastic training. We talk more about it in another episode about it. So the take home message is here, a person with poor function will always have pain. Remember that. And person with good function will protect it from the pain. Therefore, what is more important is to tackle the function than the pain. And if you improve the function, it will definitely improve the pain. right? So rehab protocols, there are so many rehab protocols and the evidence. So most of the nice presentations and research and evidence come from a famous physiotherapist. Her name is Jill Cook from Australia, Melbourne, Australia. She has published a lot of papers and presented in a lot of conferences. A lot of my knowledge about tendon rehab is from her teachings and presentations and attending conferences. That's where I developed a lot of my knowledge. I have special interest for tendons because they are complex to deal with, and it challenges you to work with the clients, and the loading patterns and the loading protocols depends on the client needs and their functional goals, and also their vocational needs as well, and the sport specific training. So that's what's really interesting for me. So eccentric exercise have evidence, good evidence that it helps with the tendon pain in here. So because tendons are like springs, okay, and imagine your tendons are like springs, and not all tendons are the same. So if I can draw for you and I can show you how the springs looks like in different tendons, you will understand that better. So your Achilles tendon is like the spring like this, and for example your patellar tendon is like that. So see the difference in this spring and this spring. So you cannot treat all the tendinopathy the same way in the lower limbs, okay? Patellar tendon has a different morphology, different loading needs, and we have to approach it a little differently because of that. And Achilles tendon, as I told you, where it attaches to the bone, we got compression load is happening here, mid portion, we have energy storage and energy release, right? And in the paratendon, in the sides here, we have friction load. So we have to deal with all these things in the Achilles tendon. So when we do the eccentric exercises here, we can see the things. It doesn't strengthen the whole kinetic chain. It does work on the little bit of elastic component of the tendon, but does not work the whole kinetic chain. That's a drawback of the eccentric exercises. And also, eccentric exercises does not adapt the tendon for different various energy loads, energy storage needs. That's another drawback. We have different protocols for the eccentric exercises. The common one is Alfredson protocol, where you do series of low load, high rep exercises for about 12 weeks, twice a week kind of thing, 12 weeks, and then see how much it's changing or affecting there. So for some patients it's work, but that's not the only thing we do when it comes to tendon protocol. So another thing we do is a heavy, low, slow resistance here. What it does is it improves the muscle strength, because when it comes to tendon, as I told you, tendon, muscle, kinetic chain, and the fascia, we have to take care of the whole thing, not just the tendon. So this heavy, slow resistance, it helps with the muscle strength, and also it loads strengthen nicely. What it does not do, it does not adapt the tendon to the energy storage needs. So that is the drawback of this kind of exercises, and also it does not provide a lot of compressive loads. What is common here with all these different types of exercise protocols we are talking about, if you notice, it's exercise and the correct loading. That is the most common thing. That is the take home message for you if you are undergoing any kind of tendon rehab. So if the exercise is that much beneficial to the tendon, why does exercise fail? What are the reasons? So here is the main reasons actually. It is not new, it's been there for a while, right? And it is slow. You're not going to get immediate effect of an exercise right away. It's a slow process. And also it's not very expensive. So maybe if we charge like $1,000 for an exercise, maybe people will do it properly. We're not going to do that, but that's why it's one of the reasons actually. It came from a research that because exercise is not very expensive, people don't do it that much. So, but exercise is the most important thing in the tendon rehab. So how can we make exercises ideal for tendons? Because we have to make sure the tendon, the muscle tendon complex, and the whole kinetic chain is being exposed to graded loads and the loading program. That's very important. And try not to any kind of a quick fixes. Do not try that. Right? It's not going to work with tendon because we know evidence suggests only the exercise and the loading patterns are the proper way to approach tendon issues, right? And also do not try to fix the structure. by different things. There are a lot of things out there, different types of injections and guru juice we call it, or different kind of modalities. Try to fix the structure, it's not going to happen. So concentrate on the function, improving function. That's what's going to work with tendon rehab in here. So how do we generally rehabilitate the lower limb tendons? You can see that the proven thing is stage loading program. That's a main thing here. First, you have to, in the acute stages, we have to unload the tendon and to settle the pain, right, and the inflammation. Then heal the tendon. Then after that, start loading the tendon gradually. Then you see how the results are coming. And the loading depends on the activity level of the patient and also the functional goals and the sports goals of the patient. So very short glimpse of the stages of rehab we're going to go through. We're not going in detail here because when you go see a physiotherapist in the clinic, and they will explain to you and take you through the stages of rehab, and here we're going to just give a small glimpse. The stage 1 is mainly pain relief and also not too much of exercises, no compressive loads. Mainly we focus on isometric exercises, which is mostly not moving the joints but working the muscles a little bit differently. The stage 2 is all about strength. We take care of the muscle strength locally and globally, the whole kinetic chain and also the involved muscle in that area. When it comes to Achilles tendon, a lot of calf muscle strengthening is important, and also whole posterior chain, your hamstring, your glutes, your core muscles, everything we have to work on, and also functional strength. Even in stage 2, we don't put a lot of compression loads to the tendon. And in stage 3 is we work on the energy storage and release. In that, this is a lot of faster loading we will do because tendon respond well at this stage for the faster loading. Not too much of slow loading eccentric exercises doesn't work in this stage. So we got to do a lot of fast loading for energy storage and release. Imagine the spring I told you, the diagram I showed you there. So imagine that spring. And also a lot of end range eccentric loading exercises we have to do, and this stage, at the stage 3, we can add some compression loads to the tendon, right? And stage 4, again a little bit of higher level of energy storage and release, and very sports specific exercises and loading happens at this stage. Is the final stage, and we will be adding a lot of compression loads also into that. For example, like if you have to give an exercise example for the stages, for example, if you're really acute, you'll be sitting down on the chair and you do the heel raises in sitting, right? And then in standing, you will do both legs, the heel raises in standing. Then from there, we can go to single leg heel raising. And then next stage, we can go into a little bit of running. Right after single leg, and we can go for running is the next stage. After running, hopping is the stage after running, and also the single leg hopping. So hopping in the same place. Then you forward hopping, side hopping. There are so many stages, so many ways to load the tendon. Just an example of exercises what you will be going through when you go to tendon rehab, and that's only the graded loading is the only evidence to prove better. So take the stage program and fit to the person and the tendon. So individuals vary markedly. Your lifestyle is different, everybody's lifestyle is different, your functional needs are different, your sports needs are different. Like I would be giving the same exercise for a 20-year-old basketball player and a 60-year-old pickleball player and a 50-year-old golf guy, right? So I'll be giving different protocols based on their needs, sports specific training. And tendons also vary markedly. This presentation is mainly focused on Achilles tendon, but we can always compare and contrast how would you treat Achilles tendon versus patellar tendon, Achilles tendon versus gluteal tendon, because I told you already briefly the tendon morphology is a little bit different and the needs are a little bit different, the loads they go through is a little bit different, and also the stages it happens in your life, it's different. So you can't take one recipe and try to fit into all the tendon rehabilitation protocols. We can't do that. What about interventions, injection therapies, electrotherapies, all of them? So they are all there. There is a little bit evidence for some of them. There is strong evidence for some of them. For example, your shockwave therapy has a strong evidence. Ionotophoresis has where you kind of get the ions into the tissues has weaker evidence. And we talk about more about it as we go along into that other sections there. They are good for targeting the nerves for pain relief, but you have to load. My take on it, if you have a poor function, intervention for structure and pain will not restore function. So you need to focus on the exercises to change function. Summary, Tendons and tendon pathology and pain are very complex. It's not easy. You have to work with your healthcare practitioner and a physical therapist to identify what's going on, what are the contributing factors, how we can work on your intrinsic and extrinsic factors, and how we can design a individualized specific loading program for you. Right? And recipe programs does not work. You can't just watch a couple of exercises in YouTube and start doing it for yourself. It does not work that way. And as clinicians and patients, we have to be thoughtful when we deal with the tendon rehabilitation. And now that's kind of end of the this episode here, and we're going to go through a couple of very interesting questions actually came from the audience, and we'll go through that and answer those questions. Okay, Anu is here. Anu has got a couple of questions from the audience here, and she's going to ask me this, and we'll see.
So the very first question is from Brad from Edmonton. He is asking if squats or calf raises, which is a better exercise for Achilles tendinopathy?
That's a great question actually, especially when we treat a lot of athletes and active adults. The squats and deadlifts are very good compound movements where you can load the tendon nicely. We can start with bodyweight squats and then go to the weighted squats. Same with the deadlifts, gradually increasing. Even though they are really good for the tendons, when you do the isolated strengthening, the heavy single joint isolated movements, we recommend actually more or less about 70% of one repetition maximum for you. How much you can lift maximum and 70% of that weight on isolated strengthening. For example, heel raises with that weight, and you can also add loading by a backpack or kettlebells on the side, or seated raises, and also standing up raises, single raises. So isolated single joint exercises is much more better for the tendon rehab than the compound movements like squats and deadlifts. That would be my answer for that question. And we have, I think, one more question from Anu.
So the second question is from Clara from Sherwood Park. She's just asking if overground running or treadmill running, which is a better for Achilles tendinopathy?
I would say overground running is better. We should prioritize that compared to the treadmill running, because the load in the peak Achilles tendon force going to the Achilles tendon area is much higher in treadmill running compared to the overland or overground running, and that's a main research evidence. So I would prefer you doing more on the overground running, but especially now we have winter in Alberta, it's kind of hard, but if you have really acute tendonitis and avoid treadmill running at least at the initial phase, and your physiotherapist can suggest you what would be more appropriate for you and what stage you can load the tendon. Yeah, compared to overground and treadmill, I would go for overground. That's the question. And thank you so much, Anu, for the questions. And if you guys like this episode and got some information about this, please subscribe for Ask Giri, the Physio Show, and also share with your friends who has problems, especially the runners and the active adults, and they can get benefit from this. If you have any other questions, you can email me at giri@physioshow.ca. And see you guys soon in episode 10. Bye.